Welcome to SDHC's Health and Wellbeing podcast. Before we begin, we want to emphasise that the information shared in this podcast is for educational and informational purposes only. While we strive to provide accurate and up-to-date content, it is not a substitute for professional medical advice, diagnosis or treatment. Always seek the guidance of your doctor or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Remember, your health and well-being are invaluable, so prioritise consulting with a medical professional for your personalised care. Hi everybody, you're listening to the Health and Wellbeing podcast from Hillbrow Health and Wellbeing and SDHC with your host, Dr Nick Harvey. The purpose of this show is to help people understand how they can help themselves and others with their health and well-being. Every episode, I interview an everyday expert to understand the latest evidence and advice on how to improve your own health or help others. Joining us on today's podcast is Hursh Gagda. Hursh is an experienced pharmacist with a diverse background spanning community pharmacy, general practice, integrated care boards, and local pharmaceutical committees. Currently serving as a Community Pharmacy PCN lead for Community Pharmacy Surrey and Sussex, he plays a role in strengthening collaboration between community pharmacies and other healthcare professionals with a primary care network. With a deep understanding of the pharmacy sector, Hursh is committed to enhancing patient care and driving integration across healthcare settings. Welcome, Hursh.
Thank you. Thank you so much for having me.
Not at all. It's been a pleasure. You're the first pharmacist to join us on the podcast, so got lots of questions for you. First of all, I was quite thrown by quite the area that you cover, actually, and you mentioned just before coming online quite how far you've had to drive. So that must bring you some real challenges. Tell me a little bit about those challenges outside of life and what keeps you ticking.
So I joined my current role as a Community Pharmacy PCN lead with Community Pharmacy Surrey and Sussex in April. Since then, I have clocked many miles on my car because we cover all of Surrey and all of Sussex, so all the way up to Eastbourne, Brighton, and more locally for me, more like the whole of Surrey. So it can be challenging. It's also very, very rewarding because I get to see community pharmacies in different areas and how they work and what their priorities are in their areas, etc. So yeah, it's quite interesting for me.
Good. And what keeps you ticking outside of work then?
I'll be honest, for me, family is very important. So I tend to spend a lot of time with my family, quality time with my parents and my wife, etc. I don't have any children yet, but I've got an 8-year-old niece and 5-year-old nephew turning 5 soon, actually. And yeah, they keep me quite busy as well. In terms of hobbies, etc. As you, when we were walking up to the podcast room, I was quite interested in seeing your cricket nets. I'm a very big cricket fan and I tend to play weekly, not professionally or not in a team or anything, but just with my friends and family. But yeah.
Great. That's fantastic. Those things like that just add to one's resilience so much, don't they?
Definitely.
So I'm really intrigued, before we start talking about anything else, is just to understand the role of Community Pharmacy Surrey and Sussex. Like, what is that? Because I think that'll be a completely new concept to people listening.
Yeah, so Community Pharmacy Surrey and Sussex, we are the local pharmaceutical committee. So we represent all the contractors, the pharmacy contractors across Surrey and Sussex. So we're just, how do I put it? We help relay the views of community pharmacy in other healthcare professions. So we liaise quite closely with general practices, integrated care boards, and we're there to help with collaborative working between two different sectors. But yeah, that's pretty much what we do.
Thank you. Because I think the general member of the public, pharmacies seem quite disconnected maybe from general practice and the wider primary care. And you're part of that glue, I guess, to actually try and help us as organisations to work together a lot better. And I think I can certainly see that day to day. But the general public probably don't notice that at all.
Exactly. No, it's not something that's out there in the public. We work pretty much in the background, but we help support our community pharmacy contractors, in really integrating themselves within.
Yeah. And I think probably it played a vital role in some of my next questions around pharmacy first, because the general public have noticed a huge change in what they can see their pharmacist for, haven't they? Tell me a bit about that.
Yeah, so well, I say new, but it's the Pharmacy First service got rolled out January last year in 2024. Honestly, when it first started, was a bit of a slow process in getting the word out there, but I think more and more patients have used the service and found it quite beneficial. And what it is, it's a new and improved version of what we used to have called the Community Pharmacy Consultation Service, CPCS, where patients can be seen in community pharmacy for minor ailments, or if it's a weekend and their GP surgery is closed, then they can get an urgent supply of their repeat medication. The new part of the Pharmacy First service is now that there are 7 conditions where community pharmacies can deal with what we call clinical pathways. And for those 7 conditions, the pharmacist can have a consultation with the patient, potentially provide some treatments such as antibiotics or antivirals if it's clinically appropriate. And if it's not clinically appropriate, they will then help them with other ways of treating their condition. The seven conditions, I'm sure you're going to ask me it later, but I'll go into it now. It includes stuff like acute otitis media, which is obviously an ear infection, impetigo, infected insect bite, shingles, sinusitis, sore throats, and UTIs, stuff that community pharmacy has seen for a long, long time. But unfortunately, we've not had the facilities to be able to treat the patient within the community pharmacy, and we've always had to refer the patient into general practice or another acute setting.
Fantastic. So just to revisit those then, to make it really clear, people with earache, people with sore throat, insect bites, or worried about a skin infection.
Yeah, it's particularly infected insect bites, but obviously we see patients with skin conditions, etc., but that wouldn't constitute under the 7 clinical pathways, but we'll treat that under the minor illness section. But I need to put it out there that for those 7 conditions, because we don't prescribe the medications for it. We follow PGDs and patient group directives, which means that we have to follow certain age ranges. So for example, with the acute otitis media, the ear infection, we can only treat patients from ages 1 to 17. That's just how the PGD has set it out. And
similarly, I think with urine infections, you've got some restrictions as to who you're allowed.
Yeah, so we can only treat females who are younger than 65, so under 64, or 64 and under.
But it's a great service, and the access is probably a lot easier than seeing a GP as well. What would someone do then? So somebody's got, they think, an ear infection, or a lady with a urinary infection, and they want to be seen. What's the next step?
So there are 2 ways of using the service. You can either walk into your community pharmacy, see if they've got the capacity on the day. You may have to maybe wait while they're they're finishing their normal day job of dispensing prescriptions. But yeah, generally you can just walk into a pharmacy and ask if you can be seen. Alternatively, if a patient, for example, has gone to their GP practice and they're not able to get an appointment on the day or in the next few days, then the general practice could also refer the patient into the pharmacy as well. And that gives the patient a bit more confidence as well, because it doesn't seem like they're just being told to go elsewhere. They're actually being formally referred to the community pharmacy. And then it allows the pharmacy to really manage their time effectively. And they see a referral on their screen. They can give the patient a call and say, "Oh, could you pop in at this time?" Which obviously saves the patient just waiting around.
It's been really valuable for us as in general practice. I find that our reception staff are able to understand which cases might be able to be seen in pharmacy. And so it's an increasing thing that patients will be asked to accept an appointment with a pharmacist, and that enables us in general practice to make appointments available for other people.
Exactly.
So I certainly find that partnership working really, really well. It's just taking a little while for patients to get used to having that offered to them, isn't it?
Yeah. I think it'll take a little while. It's a new concept, and I think once the patients have used the service a few times, they'll realize how beneficial it is to them and to the whole system in general.
I think one of the questions that I face is, so what then happens with the information? So that somebody sees you in a pharmacy, is that communicated with the practice? And then in a more broader sense, how are the practices and pharmacies working together just to have, good follow-up in these cases, education ongoing, et cetera, et cetera?
Yeah, so For example, if a patient is unable to be treated in the pharmacy for whatever reason, maybe they don't fall under the criteria for the service, the pharmacist, hopefully who have a good relationship with the surgery, will be able to just call the surgery and say, I've seen X and X patient. Unfortunately, they don't fall under the criteria of our pharmacy first service. Please, could you help them and provide them with an appointment, or could someone give them a call back? In terms of the information, like for post-event messaging, so once a patient has had a consultation and everything's fine, etc., how do we give that information back to the surgery? Well, currently how it happens is the post-event messaging would go to the surgery via NHS mail, and then that information then gets coded onto the patient's record, so the GP would have full sight of it. There is something called GP Connect, which is out there. It's not rolled out everywhere at the moment, but hopefully in the future, GP Connect can go live everywhere. And what that allows is it gives the pharmacist full access to the patient's medical records, the GP records, which will allow them to provide or give them to make a more informed decision about the patient's care. But it will also allow the pharmacist to write into the GP record. And so the GP side will be able to see, oh, this patient was seen yesterday in this pharmacy. This was the outcome of the consultation. That helps because it's a live view. So it doesn't require the surgery to code anything into the system. And so it does help in the admin side of things as well. And it also, I think it's a safeguard as well, because if the surgery haven't got full details of the patient's consultation, if that patient then went to the surgery and didn't mention that they have seen the pharmacy, then the GP may provide the same sort of treatment, or may not be able to make such an informed decision.
Mm-hmm. Thank you. So this has really gone on leaps and bounds in the last few years, hasn't it, to enable this? We've touched on then dispensing medications used to be kind of the main thing, and that's really a tiny thing on the side now, isn't it? We've now touched on this pharmacy first and the 7 conditions that you can treat. What else is it then that pharmacies offer that people should be aware of?
Yeah. So there are the services that pharmacy offers can be split into 3 different sections. So you've got your essential services, which I'll just give you some examples of essential services. So you've obviously got the dispensing of medications, as you've said. There's also discharge medicine service. So when a patient gets discharged from hospital, maybe they've made some changes to their regular medications, etc. The hospital will then send that discharge summary to the pharmacy. The pharmacy then would go through the service. So they would look at the new discharge summary report. They would have a look at any changes that are made. They would then speak to the patient just to make sure they understand these changes. They will order the medications from the surgery, or they will await a prescription from the surgery once the surgery have had sight of the discharge summary report. And then the pharmacist will then double check that the new prescription correlates to the discharge summary. So there's no old medication that they've been stopped in hospital on there, or the new ones are on there and it's the correct dosing, etc. So that's just an example of an essential service. So all pharmacies have to offer that. Then you've got things such as the advanced services. So advanced services means the pharmacy are able to choose whether they offer this service or not, depending on their capacity, etc. This includes the pharmacy first service, of course, flu vaccination when it's flu season, hypertension case finding. So this is where patients can get, as long as they're 40 and above and they're not on any irregular blood pressure medication, they can get their blood pressure checked within community pharmacy. And if it's normal, that will get relayed back to the surgery and the surgery can code it onto their system. If it's slightly high, then the pharmacy are able to offer them an ambulatory blood pressure monitoring, which is obviously the 24-hour blood pressure service. And then those readings would be read by the pharmacist. And if there's any concerns, that would be sent to the surgery. There's the new medicine service, which is when a new medication is prescribed in general practice or in any other setting, as long as it comes under a certain group of medications, then the pharmacist would then follow up with the patient after they've used the medication for 7 days and then 21 days, just to make sure that they're getting on okay, if they've had any concerns, any side effects, etc. There are other advanced services such as the smoking cessation and the new contraception service, which I can touch on as well. There are locally commissioned services. So that's the last tier. And the locally commissioned services, of course, it just depends on the area that the pharmacy is in and whether there is a need for that service. So in Sussex, we've got like sexual health services. So the provision of emergency contraception within community pharmacy. You've got substance misuse substance misuse services. You've got COVID treatment supplies. So if a patient has been told that they need a certain COVID treatment, some pharmacies are commissioned to have a stock of those medications. So to make sure that the patients always have an option and they don't go without those medications. And then you've also got palliative care services. So some pharmacies will hold a certain stock of palliative care medications. Again, those pharmacies will be on the GP's radar, so they will know that that pharmacy will definitely have those medications, because obviously they will need it as soon as possible. So yeah, it's just an assurance that there is a pharmacy in the area that will have those medications and the patient won't go without. Mm-hmm. And yeah, of course, the list I've just explained is not exhaustive. There are other services, etc. But yeah, I would be here all day if I went through all of those.
Quite. One question I often get from patients is around, can I have a blister pack for medications? And that must be a real challenge for you guys. What are your thoughts around that? And how can pharmacies help people with, I guess, compliance with the medication, remembering it when you're on lots of medications? How do you get them all right? And I'm sure, you guys are the experts in that.
Yeah. So blister packs, it's been a subject of discussion for a long, long time now. It is very time consuming for the pharmacy. However, the pharmacist would go through an assessment with the patient to see, is blister packs the actual right option for you? Sometimes it's not. Sometimes all they need is maybe a MAR chart, like a reminder sheet, so that they know when to take each medication, etc. Sometimes it could mean that because, I don't know, their eyesight is a bit poor, then we would then make the labels of the medication a bit bigger so that they're able to read it. And if it gets to a stage where they've done the assessment and blister packs are the option, is the option, and that's what's going to be the most beneficial for the patient, then the pharmacy could offer it. It's not a service which is remunerated in pharmacy, unfortunately, so there isn't any incentive for the pharmacy to do it. However, there are lots of pharmacies that do offer it for the benefit of the patient.
Mm-hmm. Yeah. Thank you. So what I'm hearing there is, actually, as a GP, we should be just saying, ask a pharmacist for an assessment, because they're best placed to help you understand what's the best way.
Correct. Yes, exactly. Or when I used to work in general practice, I used to do those assessments within general practice as well to see, is the blister pack correct for this patient? And then I would then speak to a local pharmacy who then would make the decision whether they are able to offer it or not. Yeah.
Because there are also some medications that you couldn't put in a blister pack, I think.
Exactly. There are lots of medications that you can't put in a blister pack, and of course the pharmacist, they are probably best placed to make that decision, because they deal with these medications day in, day out. So it's definitely worth having a conversation with your local pharmacist.
Mm-hmm. And what are the reasons that some can't go in a blister pack? And I guess I'm also leading into questions around timings of medications, whether you can eat with them or not, and some of that broader advice, because the leaflets you get with the medication are so exhaustive sometimes that they're more harm than good, aren't they?
Yeah, exactly. So there's some reasons why the medication can't go into blisters. For example, the medication might be in a special container, which means that when it's exposed to air or light, for example, then it can degrade the medication itself. So that's why it has to remain within its special blister pack, and as in their actual original packaging. And when the patient pops the medication out, they will take it there and then. If it's put in a blister pack, then it's more likely to degrade. Other examples of why medications can't go in is because there might be interaction with other medications that they are taking at the same time. Just off the top of my head, for example, if a patient's taking thyroxine and they're also on a proton pump inhibitor, they shouldn't be taken at the same time. So we wouldn't really put omeprazole with thyroxine in the morning. You would have to split that dose up a little bit, but then there isn't enough compartments in the blister, in the dosette box to do that. So we would then keep maybe the omeprazole out of the blister pack and advise the patient of, take this first thing in the morning, and then an hour later maybe take your thyroxine, for example.
Thank you. Thanks. It's a whole minefield, isn't it? Because using that example as well, some people would really struggle to remember to take. So then I end up having conversations saying, well, what's worse?
Yeah.
And actually, I think often in this is the consistency of how you take it as well, isn't it? So thyroxine, for example, is absorbed differently depending on how you take it, isn't it?
Exactly.
But if you're doing the same thing every day, it's probably not such a worry to changing it, because we'd be monitoring that. Fascinating. A whole another subject. And in terms of then side effects and things, so where should someone go? They think they're getting side effects from their medication. Pharmacist, GP? What do you think?
I would say there's no harm in speaking to your pharmacist. As I said, they are well placed to give you advice on side effects. We deal with it day in, day out. If it gets to a stage where the pharmacist thinks that the side effects that does need to be escalated, then the pharmacist will recommend then going to your GP. But again, it just depends on the patient's preference as well. We can't force patients to come and speak to the pharmacist, but I would suggest, pharmacists are definitely the right people to speak to regarding side effects of medication. And that's why we have the service, like I explained before, the New Medicine Service, NMS, because we understand when patients are on new medications, they are a bit worried and they're a bit anxious about taking it because they've read the patient information leaflet and they see, it can cause this, that. And the pharmacist will then, as I said, give them a call a week later or 3 weeks later to say, have you experienced any of these side effects? Or they will advise them, okay, if you do experience these side effects, please let us know or let your GP know.
Sure. Thank you. Because I think some patients are quite sceptical about seeing a pharmacist instead of a GP sometimes. So what do you say to reassure them?
I would say pharmacists have trained 4 years at university, then 1 year pre-registration. So they have a whole load of training involved in order to make these clinical decisions. To provide services such as pharmacy first, they will have gone through training as well for those 7 clinical conditions. And to be honest, those 7 conditions, even though now we are able to treat them within community pharmacy, we were seeing them anyway. Historically, we've been seeing them day in, day out. And we've always known how to treat them, but we just weren't able to do it within community pharmacy. So we've always had to refer. And I would also say pharmacists we're not just trained on diagnosing these conditions, but we're also trained in spotting red flags or spotting when a patient does need to be escalated further. So we work within our remit, and if we are unable to treat a patient or we have any concerns, we know when to escalate the patient.
Fantastic. Thank you. I think one of my other questions was around those more urgent cases, and how can we reassure people that pharmacists are trained to assess those urgent cases?
Again, it's just about, historically we've been doing this for a long time, and our training throughout university, through pre-reg, and even through we obviously, as all health professionals, we do our CPDs, so we continuously learning and we're continuously training ourselves on how to deal with patients with certain medical conditions, etc. And I just stressed the point that we know our remit, so if we do need to escalate, we will.
Yeah, absolutely. A highly trained and highly regulated profession, isn't it?
Yes, for sure. Yes.
So what impact is this making in the NHS, do you think? Are you aware of any kind of figures of the kind of impact that pharmacy is having in terms of positive on the NHS?
For sure. So we already know that there's been over 2 million consultations, pharmacy first consultations since launch. I think it's a lot more now, actually. This might be an old figure, but definitely over 2 million consultations that pharmacies have taken, and that potentially 2 million consultations which we've saved the GP practice from having to carry out. So imagine how much time the GP are now able to spend with the higher acuity patients. Yeah, it's had a very positive impact. I don't know the exact figures of how much time it saved or the waiting times, how much they've reduced, but I've only heard positive things so far.
Huge numbers. And I think you're probably selling yourself short a little bit, because some of those wouldn't have got to see a GP either, would they? So some of these people would have got worse, or wouldn't have got the reassurance they needed.
Exactly. And it's not just the general practice where we're reducing the burden on, but it's also even acute settings like A&E, etc., where patients would historically maybe have gone on the weekend if they've had a UTI, for example, and they weren't able to see a GP. So yeah, I think overall it's had a positive impact, and I think that's why community pharmacy is now being considered quite a vital part of the NHS 10-year plan, is to help reduce those burdens on and pressures on the system.
Mm-hmm. Thank you. I'm often listening out in these conversations of what the take-home message is. It feels to me like the take-home message is, remember your community pharmacy. They're a highly skilled, highly trained group of people now able to also give treatments for conditions independently. So remember your pharmacist.
Yeah, I completely agree. That's the whole point of it's in the name, to be honest. It's a pharmacy first. Just remember your pharmacy. If we're unable to help you, we will help escalate you. Just pop in and see what we can do for you. But I think, yeah, going forward, I just see more and more of a positive impact on not just patients' access to healthcare, but just reducing the burdens on the system.
Mm. So to take that theme, moving forward another 5 or 10 years, how do you see that progressing and the pharmacist's involvement in healthcare?
Yeah, no, of course. So yeah, the pharmacy and pharmacists are ever changing and evolving profession. Although the main essential service for community pharmacy is dispensing medications. It's being recognised, as I said, that pharmacists are able to play a big part in the NHS 10-year plan. So just to help improve access to healthcare for patients. Also, I should add that from 2026 onwards, all pharmacy graduates coming out of university, they will be coming out as independent prescribers. So I think it's just the world's our oyster. I think it's eventually there are going to be services where pharmacies will be able to prescribe not just under PGD, but actual prescribed medications for patients, obviously within their remit. And we've already had some Pathfinder projects. So the NHS have funded all ICBs to basically pilot independent prescribing within community pharmacies. So we have in each area a number of pharmacies that are trying this out. Mm-hmm. Mm-hmm. So yeah, I think it's an exciting future. I think it's going to take a bit of time and a bit of work to get used to. But yeah, there's a lot that community pharmacy can do.
Fantastic. There's a couple of things that we very touched on about smoking cessation, contraception. How big a role do pharmacies play in that? And yeah, when should we use you for those things?
Yeah, so there's two different types of smoking cessation services. There's the advanced service, which is obviously commissioned nationally, and then you've got locally commissioned smoking cessation service. So if a patient, for example, I don't know, they may be in a hospital and they've been advised that they should reduce their smoking or stop smoking. They would have been initiated their smoking cessation within the hospital. And then once they've been discharged, that they would be then passed on to the community pharmacy that are offering the service. And then the pharmacist will take over and have consultations with them, have checkups with them, check their carbon monoxide readings, etc., provide them with some nicotine replacement therapy to get them to the quit level, basically. With the contraception service, initially when it first came out, the pharmacies were able to provide repeat prescriptions for patients who have already been initiated on their contraception without a prescription. So, for example, if a patient went to a surgery and they've been on, let's just say, desogestrel, once they've had that initial conversation with the surgery, the pharmacy from then can then just take over. And when it comes to 6 months, when they've run out of their medication, the pharmacist will then do their checks, check what they need to check, and then provide more of that supply. Now, what you're able to do is the pharmacist can also initiate the contraception as well. So the patient could just walk into a pharmacy if they are providing that service and suggest that they want to start on a contraception. And the pharmacist will then go through a whole consultation, give them their option, pros and cons of the different options, and help the patient make a decision on what contraception they want to be on.
Mm-hmm. Yeah. Fantastic. Thank you. So I've got an interesting question from our previous guest, Hansa Raja. she works very closely with supporting families with children with behavioural challenges. And her question was, how might pharmacists get involved in supporting children or families of children with behavioural challenges and sleep problems?
Yeah. So we in pharmacy, we see a lot of patients and patients with different conditions. And we do see parents come in with their children who potentially have mental health conditions, or in particular sleep issues. Now, I would say in community pharmacy, there aren't many services where we can particularly help with that. However, we are trained in identifying patients who are suffering with mental health conditions, and we can have this conversation. We can initiate conversation with them, just say, how are you feeling today? Is there anything that you need support with, etc.? And then, even though we can't really do much within the community pharmacy at this stage, we do know what services are around us in that locality and where we can signpost this patient to. So it was really, actually, I had a listen to your last podcast, and it was really good to hear the safe space that she's created. And I think it's definitely worth community pharmacies knowing what's in their locality. And if there are those type of services, then it should definitely be in the back of the pharmacist's mind to say, actually, I know this great service. Mm-hmm. Please speak to them.
Mm-hmm. Yeah, absolutely. Thank you. So in our next podcast, we'll be speaking with Olivia Hum about the controversies around treatment of perimenopause and menopause. What would you like to ask her?
Oh, that's a good question. Oh, I'm trying to link it with community pharmacy. Oh, okay.
So I wondered whether you must face questions in community pharmacy around maybe alternatives as well to hormonal contraception. Yeah. I'm getting my words between HRT, hormonal HRT, and non-hormonal alternatives. Did you ever get those?
We do get questions a lot about HRT. It's not in particular with changing between hormonal and non-hormonal, but the main question we get about HRT in community pharmacy is to do with this HRT is out of stock. There's been a lot of stock shortages around HRT, and we've had to quickly understand, okay, what's the equivalent? What can we give instead? What can we advise the doctor to prescribe instead, for example? So I'm struggling.
So maybe the question then is, because I think that's a really good question for us as well. When I have a patient whose HRT is out of stock, I have not a clue where to go next, because you don't really know what else is in stock. So is it around how do we work best together between general practice and pharmacy to ensure we find the next best thing quickly, and how do we work that together?
Yeah.
Because that's a real challenge. I guess we almost need from you, these are the things that we've got, but equally you need from us, this is the kind of thing we need.
Yeah, no, I think it's all about communication, to be honest, between the different sectors. And that's also why I didn't touch on before, but we do have people in place called Community Pharmacy PCN leads, and which means, so each PCN has a community pharmacy representative who will basically be the middleman between community pharmacies in that PCN and the general practice. So if there is anything, for example, stock shortages, etc., to relay to the community, to the general practice, they can help do that, or they would create maybe a WhatsApp group between the healthcare professionals in the practice and community pharmacy. So it's like that really easy way of just, does anyone have this medication in stock? Someone at the surgery, maybe the practice pharmacist could put in their group, or does anyone have this in stock? And then if the community pharmacy has it, they can say, oh yes, we have it, and you can direct the patient there, for example. So I think having the PCN leads in place has been really, really helpful in that sense.
Mm-hmm. Fantastic. Great. So I'll pose that question to Olivia regarding how can pharmacy best support general practice when a HRT is not in stock?
Yeah, I think that's really good.
That's a useful one. Good. Well, thanks very much for joining me. It's been really interesting to listen to a little bit more about the mechanics of how pharmacy works. I certainly, on the other side of it, really feel the benefits, and pleased that you can kind of share how much pharmacists can do to help people, how competent you are as a group, and how well trained you are and able to deal with a host of problems that our community need helping with.
Perfect. Thank you so much for having me.
You're welcome. been listening to the Health and Wellbeing podcast, where today's focus was on the Pharmacy First initiative with Hursh Gagda and me, Dr Nick Harvey. For more information and resources, check out our website, sdhc.org.uk. If you have any feedback or suggestions for future episodes, please email us at sdhc.feedback@nhs.net. Join us for our next episode, where Olivia Hum will be coming on to share insights on the menopause revolution. Please take a moment to subscribe to help support us in empowering others with their health and wellbeing.